Hello, everyone, and welcome to the Ask Nurse Linda webinar. As you know, this is my happy day because I get to spend my time with you, which is really quite wonderful. I'll first describe myself in that I'm a lightly pigmented brown hair, mostly brown haired woman. I have clear glasses on and I have a red shirt on because it's the end of January and I'm already celebrating Valentine's Day. So I thought that would be a fun thing to do for today. I wanted to let you know a lot of people have been interested in the Superman movie, which is the story of Christopher Reeve's recovery. And that movie is going to be on CNN this Saturday night. So check your local listings so you can find it. It is, in my opinion, one of the most fabulous movies ever because I lived it and I just enjoyed every single minute. I enjoyed seeing him again and Dana again and the kids again and just everything. All that was such a heyday time, such a turning point in paralysis research, and that so much attention was being given to it and just a lot of things have resulted, looking back over the years, all the things that started with that little project with Christopher Reeve and all the wonderful things he did for our community. So it's really a fabulous movie. So I encourage you to see that if you so would like to do that. So we have an abundance of questions today. So I'm going to go ahead and get started with those. And I'm just going to call them up here. Here they are. So the first question is somebody says they're in physical therapy, but the progress seems slow at times and the nerve pain. And so they have a lot of questions about what's going on there. And I think that everybody needs to know that when you have neurological injury, either from injury or from disease, the recovery time is slow. I equate a lot of neurological disease like to the skin because you can see recovery if you get a little cut on your skin. The paper cut, it might be gone in a few hours. If it's a deeper paper cut, it might take several days, but you can see the progress because it's on the outside of your body. You can't see inside your body, and the nervous system is very, very complicated. We have learned so much about the nervous system, but I suspect that there is so much more to know. And the reason why I say is I suspect because we don't know what we don't know. So we're rapidly studying in just a lot of different things. And so I want you to know that sometimes recovery is slow. It's different for everyone. And so these are just some of the issues, that arise with this sort of thing. So just so you know that it can be slow. Like anything else, you have some good days, you have some days it seems like you're going on doing the same thing over and over and over and nothing's happening. And then all of a sudden something does. And so just know it does take some time. It can be frustrating, but you just power through, you keep at it and there will be some small improvements and there will be some large improvements. So, no matter what you're doing, if you don't see it on the outside of your body with movement or increased function, it's helping the inside of your body. So, we can't see that nervous system working inside of us, but believe me, when you're doing therapy or if you're just doing your stretches or your range of motion, it's really helping the inside of your body. So, those are important things to do. Now, with nerve pain, we have a whole nerve pain booklet that goes through all the different medications and non medication treatments that you can do. So be sure and take a look at that. It's on for everything is free of educational materials on the website. So be sure and download that information about pain control because that will be something that you'll really want to take a deep dive into. The booklets are small, they're easy to read, they're written for consumers. And so there's actually a lot of information in there if you want to do the medication route, if you want to go the non medication route, if you want to do a combination of both. Just be sure and talk to your healthcare professional so you find the right medication for you. Sometimes people will say, "Oh, I have pain. I need to take a Tylenol." Tylenol won't treat nerve pain, so that's not going to do much help. It might take the edge off the pain around the muscles of the nerve, so it might do a little something, and you'll think, well, it's helping, but it's really not solving the nerve pain. Nerve pain is a unique and different animal, so you want to get the right medication, and there's several different options. So if one isn't working out for you, you can try another one. Now, once you go on those medications, you need to be careful when if you decide, well, this isn't working. Do not stop these medications cold turkey. You need to wean off of them. If you stop them cold turkey, it's harder to start a new medication, and the new medication won't work as well if you've done the cold turkey route. And so I say that a lot, but I meet a lot of people who'll say, Linda, you told me not to go cold turkey. I did, and I'm paying the price because just exactly what you said would happen happened. So, I tell the truth. I'm a truth teller. Here is the next one is my husband has a T8, T6, T8 spinal cord injury and is paralyzed from the rib cage down. He's experiencing severe muscle spasms that tighten in the midsection and travel down both legs, wondering if there's a regimen that has helped other people with spasms. And yes, there's also medications for spasms. And you, if it's a spasm that you want to treat, or if it's a nerve pain you want to treat, you want to talk to your healthcare professional to identify the source of the problem so you make sure you're treating the correct thing. Sometimes people treat pain and spasms together, and so there's options for that as well. And so there's just a lot of choices in the treatment of these two conditions. And you'll see over there in our chat box, you'll see some links to these to this information. So that this is all good information for you to have. Again, you can download it for free if you want to take it with you to your doctor and say this is all reviewed information. It's up to date. So if you want to take it to your doctor and say, I got this from the foundation and I was wondering about this, sometimes if you go in and you say, "Oh, I read this book and I've decided this is the medication for me," that's kind of a bit aggressive. So sometimes if you say, "I was wondering about this one," or "Can you tell me if you think this one would be effective for me, or if you would recommend one of these others?" Your healthcare professional is the one who knows your medical condition. We speak in generalities. Here's the list of all the medications. It's not like a menu. One medication you might be allergic to, it might be contraindicated to some other medication that you take. So you always need to check with your healthcare professional to get that down just right. Now, oh, here's a really great question that has not come up before. Because it's a pretty common question that I see out in the community, but I don't think I've ever answered it on this webinar. And that is, how do you feel about silver catheters to help with UTIs with a Foley? That is interesting. It's an interesting concept because silver catheters were developed with a coating of silver. It's not like silver like silverware, it's real silver, but it's a coating of that on the outside of a catheter and the inside of the catheter, so that silver is a known bacterial retardant. So it stops bacteria from growing. And so they put silver in these catheters, and they were a big deal for a long time. Everybody wanted the silver catheters to protect from UTIs, but they've done some research on them. Now, there's some research that say that a silver catheter is about 40%, between 40 and 44% more effective in treating and preventing urinary tract infections than a catheter without the silver. There are other studies that say we're not so sure about that. So the research is kind of a little bit on the fence if that would be something that would be worthwhile. Silver is a heavy metal, and so it might have, for some people, not for everyone, but there might be some toxicity to it over time. There's also been some, and that again is very weak evidence. So I don't want to be putting something out, oh, I can't do that, it's toxic. Talk to your healthcare professional, understand the risk, understand the benefits. And so, and then make your health decisions with the guidance of your own healthcare practitioner. But there's another thing about the silver is they think that the silver might wear off or wear down or become less effective before it's time to get a new silver catheter. And so you might have coverage for some parts of the time and not for other parts of the time, which could have something to do with the effectiveness, depending on when somebody was doing the study, when they took the sample. Was it after the catheter was first put in, or was it before the catheter was changed? So there's a lot of variables out there. So even though these have been around for a splendid amount of time, there's still more evidence that needs to be collected. So if you think that that might help you, talk to your healthcare professional, see what they think about the issue. They might be like, oh, with your health condition, I think it would be just fine if you want to try that. So, you could go ahead and do that. Now, they might say to you, I don't know, you have some conditions, or I'm worried about this, I'm worried about the other thing. And they might say, I wouldn't advise that for right now. So again, talk to your healthcare professional because you don't want any interactions in your body that's going to affect you negatively. So be sure you talk with a person who knows about your health risks. So that is the thing about the silver catheters. They were all the hubbub for a while, but a lot of people couldn't get them because they were so expensive. But I think the price has come down into a more reasonable pricing category. So I think they are more available than they used to be years ago. So anyway, I don't hear a lot about silver catheters anymore because they kind of went away from them for a while, but now it seems like they're having their second tide of notoriety, so to speak. So that's the way healthcare goes. We figure out something and then we learn a little more and we think, oh, maybe that isn't the best course, and then we get a little more information. And we think, hey, maybe we should go back to that original idea. And so, that's the same thing that happened with electrical stimulation. It started out, was a great idea. People were doing it. It was very expensive. It was very complicated. The equipment was unwieldy. And then somebody else thought about it and said, we could make this more practical. And it's gotten more practical and more practical and more practical and more affordable. So more people are getting these things. So that's kind of the iteration of healthcare research. Another very interesting question is, could you provide information about treating heterotrophic ossification? Now, heterotrophic, whichever you choose to pronounce ossification. So those are big words. So we call it HO. You might hear about HO before you hear those words all spelled out. But anyway, HO is a condition that happens sometimes, not often, but it's one of the more common uncommon consequences of injury to the spine or to the brain. And what happens is where your bone, like your skin, like your nervous system, like your heart, all of the cells in your body are constantly turning over. And so new bone is being made all the time. And so it comes from the bone marrow inside your bone. And then those cells are released and they go to the bone and they replenish the bone, and bone cells that are old and tired, your body discards, and new bone cells are being produced all the time. And so, but what happens with the nerve communication, perhaps maybe something to do with the autonomic nervous system, and the control of this bone formation. Sometimes the bone cells get lost in their path from the inside of the bone to the outside of the bone and stages in between. And sometimes those bone cells get deposited in the muscles, most often near a joint. That's why I'm pointing to my shoulder, because most often it's in the shoulder and the hip and the knees and the elbows. Sometimes I have seen some rare cases and very extreme cases where people get it in the joints of their finger, but that's pretty uncommon. But it's usually the bigger joints is where you usually get it. And so the bone is actually growing into the muscle, which can make it very, because bone is not mobile, muscle is mobile. And so when that bone gets in there, the muscles get stiff, it's harder to move that joint, and and the it starts calcifying outside of where the where the joint is. So it's the whole muscle becomes like bone. Now, when I say the whole muscle, it enters the whole muscle. I don't think I've seen one where the whole muscle around a joint has completely turned to bone because usually people have trouble moving their arm. They don't understand why. They go to the doctor gets just a plain x-ray, and then you'll be able to see the joint, and then there'll be some haziness in like little sporadic patches around the joint. And it can be quite far from the joint. Most of it will collect closer to the joint, but it'll kind of spread out over time. That's that bone deposited in the joint. So once you see an x-ray with that on there, you're like, oh, that's HO. I know what that is. And so there's ways to treat that. So if you have some stiffness or some soreness, a change, an abrupt change, sometimes we're stiff and sore from other things. Even though you have neurological injury, you can still get arthritis. You can still get cancer. You can still get other diseases. So you have to define what it is that is the problem so that you get the right treatment. So a plain x-ray will help diagnose this. And so one of the first things that they will get if you catch it early and you get early treatment for it, they'll start with non-steroidal anti-inflammatories, the NSAIDs, and they'll start with those, and that will help decrease the inflammation, and sometimes that will just take care of it. So that is a good thing to take. Now, if you can't take those for some reason, you have some problem with your kidney or you have some other medical issue, there's also some biphosphonates. There is a new drug that's out on the market, and it's called, I have to look on my paper because I thought, oh, I have to remember this. It's called palovarotene, I think is what I've written down there. Yes. And it is only for a disease that's called Fibrosplastia ossificans progressive. So it's only given for that particular disease. It only works in that. That's all it's allowed for. So why do I bring it up? I bring it up because once if they prove that this drug is effective in this diagnosis, they'll start testing it, and maybe they already are testing it in other diagnoses. So I just like you to know that there are things on the horizon as well. People are working on this. It is an issue, as I say, it's not a really, really common problem with spinal cord injury or with head injury, but it does occur. In the uncommon things, it's pretty common. So I like to think of it that way. Now, if the condition gets so bad that the joint becomes frozen or it's just so much, they will go in and do surgery to release that joint. They might put in an artificial joint replacement, or they might use radiation therapy to help this abnormal overproduction of the bone cells. So there's all kinds of things. It's good to catch it early because, like anything else, you catch it early, you might be able to take a medication as opposed to having surgery, which is going to put you out of commission. If it's in your shoulder, you might not be able to propel your wheelchair. If it's in your hip, you might not be able to sit for a while. And, there's just surgery is always more complicated. If you need surgery to get back to where you were, well, then it's probably well worth it. But, it's always better to catch things early. So there's physical therapy that can be done to help with this condition. And, of course, prevention is always the key to everything. Don't get it in the first place. So prevention is very helpful. If you do your stretching exercises, it has a lot less chance of that freezing the joint if you keep your joint mobile, if you keep doing it. If you notice that there's getting to be some pain in that joint when you're doing and you didn't have that pain there before, or you can't move the joint as far as you could move it before, then you'd want to check with your doctor and see, because that catching it early, you can treat it early, and it's a lot less work for that kind of treatment. Okay, let's see if we have any questions that have come in. Um, the foundation of the thoughts on stem cell treatments. Well, stem cells were quite the thing, quite the range. And I'm gonna say, like, over 20 years ago, it was all over the news. It got very complicated, and, people are still very much working on stem cells. Stem cells are cells in the body that are newborn cells, and by newborn, I mean, like, like I say, you have these cells in your body that are always being replenished. When those cells are first born in your body, not in a newborn baby. When they're first born in your body, we call those newborn cells in the body. They can grow up to be anything that they should be. So if they go to their heart, there are chemicals in your body, chemical reactions that will make those cells become heart cells. And if they go to your brain, they will make those cells become nervous system tissue. If they go to your skin, it'll make skin cells. And uh, the scientists have learned how to make those cells become nerve cells every single time. You certainly don't want to get some stem cells and put that are destined to be heart cells or have been chemically altered to become heart cells and put them in the nervous system. They aren't going to work there. It's going to cause trouble. So you have to make sure when you get those cells that can become anything that they become the cells that you want them to be. And we know how to make nerve cells. So that's good. And there's a lot of study that's gone on. They're still refining that, still making that better, making improvements all the time. But another thing is getting them in to the brain or the spinal cord, because when you have an injury in your spinal cord, the injury forms in the center of the spinal cord. So you'll have nerves surrounding that. If you put a needle in there, you could damage some of those nerves, getting them into that hole in the spinal cord. Well, you don't want to make more damage. So you have to think about, so they've created ways to help with that. They've created, biological scaffolding so that the stem cells can grow in the way that they need to grow in the spine or in the brain. They've done the same for in the brain. The brain injury can occur anywhere, but there might be healthy tissue that you might have to go to get to that injury, so you don't wanna cause more trouble. So they're still working on a lot of these refinements in the program, trying to get it. My personal opinion is I think it will be a piece of the puzzle, but we're just not quite there yet. Again, the nervous system is very complicated, and there's so much we don't know about it that we take giant leaps forward and then we learn something new, maybe because we were studying something else, or maybe because of the stem cell research. Now we've learned something new, and now we have to go back and kind of look at our playbook from what we've been doing and alter that to accommodate the new information. So that is really going on a lot. And there's some companies that have made some terrific headways in this. And so, as I like to say, that's going to be part of our future. I think that will come in our lifetimes, but I have no idea when. So we have to keep that, in our thoughts, that keep those people working on these things so we can take advantage of anything that we possibly can. Somebody has written in that they've used an antimicrobial catheter, so it has some kind of coating on their catheter for 20 years. Now, I'm sure it's not been the same catheter for 20 years, because I'm sure it's just the same type of catheter, because you can't have a catheter for 20 years. And it helps with, for him, it has helped with not getting any infection. And I'm glad you brought up that statement, because people's autonomic nervous system, we're learning a lot more about the ANS, autonomic nervous system. That's the part of our body that's controlled by the brain. The message is transmitted through the spinal cord that does automatic function. So our heart beats without us thinking, contract heart, relax heart, contract heart. We can't be thinking about, we breathe automatically. We don't think, take a breath in. We can't be thinking about all these things. If something gets in our eye, we'll automatically blink. It's all those, our bowels work automatically. We don't have to think peristalsis. Come on, let's get going. So there are all these things that work automatically in the body, and there's so much about the ANS that we do not know, but we're learning. And people have taken a particular interest in the ANS in particularly because of infection. So, why do some people do everything right and they have a urinary tract infection all the time? Other people, they're just kind of haphazard with their care and they never get one. So, why is that? Well, it's probably because of the way the autonomic nervous system is working. And there is a way to evaluate the autonomic nervous system, but the test is so risky, that it's not worth it. You don't want to go in for a test to find out something and oh, well, we had this horrible consequence because of the test. So they don't really do the test. There is a test that can be done, but nobody does it because it's just too risky right now. But the other thing about it is that we can tell from other things. People who have a lot of infections, we know they probably have a lot more injury to their autonomic nervous system. People who don't have much infection, people who don't have much pressure injury, people who have less autonomic dysreflexia, they probably have a stronger ANS. Now, this is all speculation, but you can kind of take from the evidence presented and make some deductions about that. So I'm happy that catheter's working out for you. Maybe you've got a strong autonomic system, maybe you don't, and it's the catheter's making all the difference. But again, you'll need to talk to your healthcare professional. So there's different kinds of catheters out there that will help with infections. And so if you have so many infections within a certain amount of time, insurance will allow different catheters, and your healthcare professional should be able to walk you through that maze of insurance things. Um, Opinion on suprapubic catheters. Do they reduce UTI? Pros and cons. Quadriplegics with caregivers who aren't at all careful with their hygiene. Oh, I'm sorry to hear that because you really want your caregivers to be washing their hands and paying attention to those details. So, suprapubic catheters have always been carried because there's an opening in the abdomen and the catheter goes in, and as opposed to intermittent catheter where the catheters goes in and out the urethra, so there's not an open conduit there. It's only when the catheter's in is there a conduit to the bladder because the urine's coming out. The suprapubic remains in all the time. So there's always an open conduit into the bladder. So the thought was for a long time that there were more infections with suprapubic catheters, but the current research is finding that there's really not much difference. And it all depends on how the infections are counted. So if somebody goes into the hospital and they get an infection, day one, that's an infection. Day two, that's also counted as an infection. Day three is counted as an infection. So you've had one person with an infection for 3 days, they've had three infections by count. So it's the way the metrics are being done. Now that the number of days of infections is important for other things. When the infection was obtained is important for other pieces of information for the hospital side of the system. But for the patient, it's one infection, it's not three infections. So a lot of these, we're finding that, these haven't jived together. So now that they're looking at infections differently, they're finding that there's not much difference. Now, there's also suprapubic, there's also another option that is called the Mitrofanoff. And this started in pediatrics. And it started with little kids who were having difficulty catheterizing themselves, mostly done with little girls because in women and girls, the anatomy is not as obvious as with men. And so they started taking a piece of the appendix and rerouting it so that it made a conduit from the navel to the top of the bladder. A catheter is threaded through that hole, through the navel, and the urine is drained out, and then the catheter is removed because the opening is above the bladder, so urine doesn't typically spill out if the catheter is not in there. And so when they started doing that with children, and then they said, "Hey, there's a lot of women out there that would really love it, to be able to do this. They're going to work. It's difficult to get in position to catheterize." you can't see where you're going. It's a complicated process. You eventually, like you learn to type, you eventually learn to find out where your urethra is. But in the meantime, this mitral fan off is so much more simpler. So a lot of people were using that one, and there's not that big of a difference. So if you're worried about a suprapubic, you might want to think about a mitral fan off. Now, some men get mitral fan off. Sometimes they have retracted penises. Sometimes they have a bit of a belly and it's difficult to get to the opening. So, it can work for a variety of people. So, you really have several choices here. Now, there are other people who have different problems and they might have a urostomy and they might catheterize through that. So there are other things. But now, if you get one of those, that's because you have other problems rather than I just need to catheterize. That's the end of my issue. So again, these are all kinds of things that you need to think about. What do you think about vaccines for recurrent UTIs? I know that they're out there and I know that they're available. I th- there's some research that says that they're successful. Um, So, we just need to stay tuned with that and follow that along. Again, when we have something new, you want to see sometimes, let's see how this goes. But I know that there are people that are out there that are doing that find success. There are other people that are out there that maybe they haven't been so successful. So we have to see how that goes. Okay, contracture of one arm. Can it be reversed? Why, yes, it can. And there's several ways of doing that. Again, if you catch it early, you can do your stretches and kind of work through that with a physical therapist. They'll give you some extra things to do. They'll show you how far to push because you don't want to just take that contractured arm and just straighten it right now because that's going to rip the muscles. The muscles are contracted. That's where the contracture word comes from. They've shortened. So you can't just straighten it right now because you're going to rip those muscles. It would not only be painful, but it's going to take time for those muscles to heal up, and so you need to just find out how far can I stretch it. I can stretch it this far. Okay, then I go back to the physical therapist. Now you can stretch it this far. There are also devices that they can put on the arm. Where's my arm going? um but it's disappearing. You can also put devices on there, and it's got a little dial on there, and so they'll adjust this dial and they'll slowly stretch out that muscle so it doesn't get torn or hurt. And then of course there's also surgical option where they go in and they take and do like a feathering um, uh, s- scalpel. So they take a scalpel and they cut the muscle, but in a feathering pattern. They don't cut the muscle. Just lightly feather it a little bit, so that allows you to have some stretching, and then the other muscle fibers will grow back because it's so few about it. So there's a variety of different ways that you can do. Sometimes people will use therapists will use a paraffin bath so that you might dip your elbow if the contracture is in your elbow, or if it's in your hand or your fingers or your feet, or they might wrap paraffin around the ankle, or they might wrap paraffin around the knee, maybe use a heating pad to get the blood circulating so that you can stretch it a little bit further. So there's working with your physical therapist will really help get that. But yes, contractures that can be reversed. Yes, they can. It takes time. It's not always a pleasant experience. It can become painful at some time, especially when on the day that you stretched a little bit further. It's like any kind of stretching exercise. You don't want to overdo it. You want to follow the prescribed amount of stretching. Can doctors, surgeons mimic the natural curvature of the spine when fusing? Yes, they do, for the most part. And I also want to bring out the fact that they have new rods that they can put in that are flexible. Now, it may work for you, it may not work for you, but when they're doing fusion of the vertebrae, so when there's supporting the vertebrae, they'll put rods along the spine, and that will hold the vertebrae in place. And so sometimes you need the rigid rods, and so that then you don't have the flexibility in the vertebrae. But these flexible rods, they don't flex that much. They're not gonna completely flex, but they'll flex a little bit more, which takes some of the tension off those vertebrae. So when they're fusing the spine, usually that's what they're doing is they're putting rods. Now there's different surgeries where they're actually taking the vertebrae and they're fusing them so that two vertebrae won't be slipping off the path there. So there's two different kinds of surgeries, but yes, they do take into account um, the natural curve of the spine if they can. If there's so much damage, they might have to just put in straight rods to just get the spine in alignment. So it depends on the difficulty of the surgery, probably more than anything else. But they would like to mimic that because, like you say, it's more natural with the way that our bodies are built. Okay. Oh, yes. Somebody's written in a question that I haven't yet gotten to, but yes, there's a question about alternating air pressure cushions, the J versus the Rojo, and is there any research or anecdotal about this information? Now, this is going to sound like a snotty answer, but it's not a snotty answer. It is the answer. So, the best cushion for anybody is the cushion that is right for their body. So, there's not a cushion where you can say, this is the magic cushion. This will work no matter who you are, what you've got going on. So it's the cushion that is the right one for you. So, some people need more support. Some people don't need so much support, but they maybe need more positioning kinds of things. So there's kind of different levels. So the first level is the gel cushion, or there's some air cushions, and they have usually some kind of perforated top layer underneath the skin of the whole thing that will help give some areas where there's a little more pressure, a little less pressure. So you're not just sitting on one flat surface. And so those are probably the most simple ones. Then you get into more of different kinds of gels, different kinds of foams. And I want to say too that sometimes people think, oh, well, my pillow's cushy. Maybe I have a pillow with foam inside of it, so I can sit on that. That foam is not medical grade foam. Medical grade foam, the cells of the cushion is made differently, so they don't collapse. So if you sit on a pillow, the pressure of your body is going to collapse that pillow, and you're making more pressure. You make more pressure if you have a lot of fat where you're sitting, or where you need pressure relief, maybe along your back, um, because that fat, again, collapses. It doesn't disperse the pressure out. And then also, if you are very thin and have not much um, meat on your bones, and by meat I mean muscle. So you're a very thin person, your muscles are smaller. So if you're more petite type of person, you're at higher risk, along with the same with person who has too much tissue in their body. So normal weight, of course, is the best, but there's not very many people with a normal weight. I can tell you that. So which cushion is the better? Rojos are nice because they have those fingers, so those projectiles. So when you have your bony prominence, it kind of will stick down in those cushions and the weight is supported around. And then there's also these alternating pressure mat cushions that you can sit on. You can get them on the back of your chair as well. And so there's usually four chambers in the ones where you're sitting. So one quadrant will go down while the other three have more pressure. And then maybe the quadrant in the back will go down while these other three have more. And so it rotates around, it alternates where the pressure is so that you are always changing position. So how do you know which one is best for you? Well, you can go to your therapist and they have a thing called pressure mapping. And if you've been to the store and you were going to buy Dr. Scholl's insoles, they sometimes have this thing that you scan on, and you can get an outline of the bottom of your foot and it'll show the pressure points on your foot. which is basically the ball of your foot, the heel of your foot, maybe along the outer side, maybe the toes have a little pressure and it comes out red if there's a lot of pressure, and blue or green if there's not too much pressure there. But you can have your whole body pressure mapped. And so then you can select the cushion that's right for you. So it's not a matter of going to the store and saying, well, this is the most expensive one. This must be the best one. Or this one is, you know, built this way, so this is the best one. So you want to get yourself pressure mapped, and then they'll be able to tell you from that which would be the best cushion for you. As I always like to say, there is no cushion that is going to completely eliminate pressure from your body because I'm sitting right now where I'm sitting, there's pressure. I don't have a spinal cord injury or a head injury, but I can feel sensation, and I know that the way I sit, I always sit with one hip a little bit higher than the other because I broke my leg years ago. I mean, a long time ago, but there are changes in our bodies for all kinds of different reasons. And so I know I have to be real conscious to not put so much pressure on this one side. Now that I'm talking about it, I'm reminding myself. And so, when we're um, those of us who have sensation, when we're sitting, we're moving, we're twitching, we're doing these things all the time because we're getting these little sensations from our body. Again, the autonomic nervous system. My brain doesn't sit there and think, oh, wow, this really hurts, unless I've been sitting on that one hip for too long. Then I'll think, oh, wow, this really hurts. I need to get up and move around a bit. So if you're not getting those autonomic responses, you're not making those constant little twitches that we're all making. If you look at somebody sitting still, they're never really sitting still. They're moving forward a little bit. They're tilting a little over here. They're moving a little bit. You really need to look at your body habitus that you have. You need to look at, have you had pressure injury? If you have, you probably need a higher level, but we don't want you to have pressure injury. So we want you to get the right cushion for yourself. And that is the way to go about to figure out which one. So that is the research about it. And anecdotal is really, some people, they get a cushion, maybe they've had pressure injury, they find their magic cushion and they're like, oh, this is the one. And that is for them, but it might not be for the next person. So it's really a trial by error. If you go to a larger facility, sometimes they'll have agreements with different sales representatives and they'll let you try a cushion. Sometimes medical supply stores, not very many, but sometimes you can go to a medical supply store and say, I'm trying to find the cushion that's right for me. Could I try this one for a week or could I try that one? Some companies, if you order directly from the company, they'll have those trial periods. Again, it's a hit or miss kind of thing. I don't have a list of who does it and who doesn't because it changes all the time. So that might be something that might be, that would be the way to go about that. So I'd like to know about, speaking of which, I'd like to know about increasing muscle mass around the buttocks and to improve and prevent pressure sores. Please, oh, please, thank you for asking this question because you do need to build up your muscle mass. The muscle is the cushion over that bony prominence. So if you have a really thin rear end, if you have, people sometimes they're like, oh, it used to be, oh, I have this very flat rear end, and now it's the bigger rear end is more in fashion, but that's more fat and other tissue. So what is the best is to build up that muscle tissue, and there's several ways you can do it. You can do it by resistance exercises. Now, if you have paralysis, that might be hard to do in the legs. There's some electrical stimulation that can be put on the muscles that will make that muscle expand and contract so that it will build up that muscle a bit. The FES is functional electrical stimulation will really help build up that muscle. But if you can't get the full FES thing, there are smaller devices. You maybe have seen in the past there was a device that you put on your abdomen. It would make your abdomen flat. because it would strengthen your abdominal muscles. So they're kind of like that, but you really want to get a medical grade and work with somebody who knows what you're doing. A lot of equipment is available online. I don't really recommend just going buying something and trying it out because again, it might not be the right thing for your health condition. So you really have to be careful about what you're sampling and what you're doing. So talk to your healthcare provider. See if you can go to therapy. Now, just about everybody has 2 weeks of mobility training. Now, building gluteal muscle, you might not think of as mobility training, but if it helps you sit, and you're in a wheelchair, sitting in your wheelchair is mobility. So you can kind of work around that a little bit and try to get that done. Here's a female, and they didn't know they had a cult spina bifida till they were 50 years old. That in the spina bifida world is not uncommon. I'm not in a wheelchair, but I have all the symptoms that somebody has with spina bifida. Is there a support group for someone who has a cult spina bifida? Well, at the Reeve Foundation, you can contact our mentoring program and they will find somebody who has something similar to you. There's also a Spina Bifida Foundation that you can contact. They work with children, but they have adults in there too. So, there's a lot of different opportunities for spina bifida, but I would start with the Reeve Foundation and talk to them in their mentoring program. I'm a 20-year-old T12 complete. Lately, my thighs are larger and swollen. Any ideas? I'm located where there are no SCI specialists nearby. So, talk to your primary care physician. Talk to if you have a neurologist, you might be able to talk to them to see why your thighs are so larger and swollen. It could be from a variety of things. Maybe your wheelchair is too small and the pressure's pushing up against the side of your legs. Maybe when you transfer, something's being injured when that's happening. Or maybe it could have something to do with cardiac condition. Maybe it's from sitting too long. Maybe it's from wearing too tight of pants. So there could be a medical reason, or there could be an equipment dressing sort of reason. When the real tight jeans, the skinny jeans were in style, I would have a lot of people with problems. Now, I'm not minimizing your problem. This is something that needs to be looked into because it could be a blood clot, it could be something very serious. Um, it could be a clot in both thighs, or it could be up maybe in the groin area that's causing this back up into both thighs. So it could be something very serious. But I do say we saw a lot of this when people were wearing their pants too tight because that crease in where you sit, where your top of your leg meets the bottom of your torso. And if you have something digging in there, like too tight of clothes, or if you're wearing Ted hose that are too tight, thigh high Ted hose that are too tight. Sometimes it's those simple problems that can be handled right away. But talk to your healthcare professional because you want to be sure you don't have a blood clot or some kind of lymphatic problem that's going on in there. What about research to help people with respiratory difficulties, cough assist, electric stimulation to help them cough? What's new? Well, probably the newest thing is the diaphragmatic stimulator, which is an implanted device, but there's an external control which helps the diaphragm go up and down. And we actually have a professional um, webinar on that with Dr. Raymond Anders, which is very interesting. That would give you a lot more information. The cough assist is very nice. Some people have a hard time getting used to it, but once they get used to it, they really like it. The electrical stimulation to help people cough. They're doing a lot with different nerve stimulation internally and externally to help people give them that extra power to cough. Sometimes wearing an abdominal binder will help give you because that will cinch in your abdomen so it doesn't take as much force to breathe in the air and cough it out because your muscles are tightened with that abdominal binder. So there's a lot of things that you can do with that. What do you think about sphincterectomy to avoid bringing a catheter? Well, sphincterectomy is where it's a surgical procedure where they go in up through the penis and they cut the internal sphincter. It creates an opening so that um, the urine will flow out. It's done mostly for people who have autonomic dysreflexia that's triggered from an overflow bladder. So the catheter gets clogged a lot, so the sphincterectomy is done to relieve that problem. But you will be rendered incontinent. So you want to avoid bringing a catheter, but you're going to switch bringing a catheter if you're doing intermittent cath to wearing a diaper or an external catheter to contain the urine. So it's gonna leave you incontinent at all times. So that might not be, I don't think, probably the solution to avoid bringing a catheter. Chronic fatigue. Um, in an otherwise healthy person. And so they've gone through all these tests. I'm sure they've gone through looking for mono and all that. I tell you, being having a spinal cord injury, even at T12, is very exhausting. It takes more energy to move yourself because you're moving with your arms, you're picking up your legs, you're propelling your wheelchair. It's very tiring. And then there are other little hidden sources of energy use in that if you think about riding in a car, you don't notice it if you don't have a spinal cord injury. You don't really notice it because the autonomic nervous system, when you're riding in a car, automatically tenses your body just a little bit. So, cars are jiggly. They run very smooth these days, but they're still a little jiggly. And there's movement when you turn, and your body, kind of will turn with the car. And so there's a lot of movement that goes on with riding in a car, pushing yourself in a wheelchair on bumpy surfaces. Sometimes it's very fatiguing to the body because you're only able to use the muscles that you can use. So even if you have a low level injury, it's much more significant in the higher level injuries, but you're using more energy. So if you've been out looking for this chronic fatigue, and you know you're working out daily, which you need to do to keep your muscles active in your body that has sensation and movement, and in the part of your body that does not have sensation and movement. So you're keeping your body going. And if you want to keep up with your tests, you should follow your doctor's advice to see, because it could be some health issue. But just know it takes a lot more energy to maintain and live with a body that has some paralysis in it. It's just more exhausting. If you're working out, make sure you're not overworking out, but make sure you're working your lower body as well as your upper body. My ribs and muscles are tighter on one side, and that's affected my positioning, and put a twist there too, but doctors don't see it. They need me to be very crooked. I don't think they want that. How can I make sure I undo this daily, not once a week in a 30-minute PT session? Just common sense for me. Should I put a slope thing under my cushion? It annoys me that I'm fine tuning is not a priority. So if you keep mentioning that you are feeling twisted, it may be that you're feeling twisted. You might be getting some kind of tone in that part of your body that is not yet visible to be seen, but it's coming. But keep suggesting it, and then find out what they're doing at that 30-minute PT session. People go to PT and they think, okay, now I've done my therapy, it's over. You have to keep up with your PT at home. So you have to keep doing it and keep doing it and keep doing it. If you need to take pictures, ask if you can take pictures so that somebody can help you do your therapy at home, or write a list of, first I do this exercise, then I do this exercise. So PT does not stay in the PT session. You should be continuing that. And if you continue that, you're going to see more and more improvement in this, because, yeah, 30 minutes a week is probably not going to cut it, but they're going to teach you how to do it and find out how you can continue your therapy at home, maybe twice a day, or if you find you need to do more. Now, if you start putting something under your cushion, that can be a little bit tricky because, you might put too much under there. It might not be the right cushion that you need. You really need to get advice on what should be done about that. If you're finding that you're not getting success in your PT session, talk to the head of PT, talk to your healthcare provider and say, maybe I'd like to make a change. Talk to your PT and say, I just don't feel like I'm getting what I need. I have this problem and I don't feel heard. I need you to work more on this. If you could help me work more on this problem. Sometimes, we think we're trying to communicate, but sometimes people are so busy in their life that they're really not getting it. So, really make a point of that and continue on with what you need to do, which continues at home. Will the physical therapist be knowledgeable to do the electrical machine and the buttocks muscle? This is in our previous conversation. They should be knowing how to do that. And if they don't, they might refer you to somebody else for that particular thing. Some people are not that familiar with the electrical stimulation. So they might refer you to another person or they might bring another person into your class. And so that is something that will, might happen. We need a sex class for women, please. Okay. There is a booklet about female sexuality and a lot of female sexuality information on the Reeve Foundation. Plus, I will let you know in the coming months, and I'm forgetting what month it's coming in already. I think it's in May. They're going to be having a women's health class. So, through the Reeve Foundation. And so all of that is coming. We have information written. There's videos if you go to Craig Hospital or if website, or if you go to Shepherd Centered website, they have some videos with people who are clothed, so it's not really offensive, but they'll show you some different techniques and positions in those videos. And I think the link to those videos are in our book, please. So in our books. So all of that you can get the basics now, but you're going to have more coming up shortly. So thank you for that little plug. Um, Oh, how long would it take? And we're back to that building up the muscle in the buttocks. How long would it take? I have no idea how long that will take for you in particular. Some people it builds up really fast. Some people, if you have lower level injuries, that the electrical stim doesn't work as much in the lower level But if you try it, you might be able to get something. They might be able to stimulate your back up further if you have a lower level injury that might help with the buttocks building. Um, I don't have muscles in my shoulders at C4. What can I do to replace them? Well, um, you can't replace your muscles, but there are these functional electrical stimulation things. If you go to Onward or SpineX, and there are some other companies that will probably come up shortly in the chat box. Reeve Foundation works with a bunch of companies that are doing things to stimulate the spine externally on the body that gives you a lot better hand function and some arm function. So, these are things that are coming to fruition, and Onward has had their product is out in the world, but not generally out in the world, but it's in the process of being marketed. So it's in limited areas right now, but they have a marketing plan. They have approval from the FDA, and they are having. It's just been released. I want to say within the last month or so. It seems to me like it was a month ago, but life goes by so fast. It might have been 2 months ago. But anyway, if you look them up on the online, you'll find that they have equipment that will be coming to a site near you soon, as will some of the other pieces of equipment that are available. And let me just click over. I know our time is up, but I think there was one more question that somebody wrote in, and I want to make sure I get to them all here. Oh, yes. There was a question about a person who elected due to the parents aging, who are the person's caregivers. They elected to go to a facility where they could get care. but I think there is some difficulty in getting the care that they need. And so, when people, excuse me, when people with paralysis from any source they need certain things done. You need your bowel program at the same time every day or every other day. You need to be catheterized on time or there's problems. You need to be turned at certain times. And those are just the basics, bowel, bladder, and skin. And then there are other things that need, if you have a splint for your hand that helps you feed yourself, you need that put on in the right way before you eat. And so there are all kinds of things. So if you get the basic care books from the Reeve Foundation, bowel, bladder, skin, and offer them to the facility, they're free. So, you could get several copies for them and maybe make a schedule in some way because, sometimes in paralysis, the schedule on some things is very rigid, but in facilities, hospitals, nursing, long-term care facilities, they work on a priority basis. Oh, this person's wet, so I have to go change them. Oh, this person needs such and so I need to suction them, so I have to go do the. Your bowel program can wait. No, it cannot wait. And so getting those points across to people, you're not asking for special attention. You're asking for the care that's needed to maintain your body. So have a meeting, maybe bring your family, have a meeting with the director of nursing, provide this information to them. Stress that you're not asking for special care. These are the things that are requirements to maintain your health. Now there will be some resistance because that's not the way they work, but if you keep at it, you provide the information that's there, I think you'll meet with some success and then just keep at it. As you get to know the assistants that will be in doing this care for you, you'll find that there are some that, okay, they get it. They'll be right on top of it and they'll understand once they see this is published information. This is not something that you're like, I need this right now. It's no, it's not that kind of way. It's because you do need this right now. And it will make their life easier if they're doing a consistent bowel program. The caregiver's life is much better if they stick to the schedule because that's the way the bowel works. And so if you talk to them about that, it's a benefit to you and your health. It's a benefit to lower their work labor because if they are not giving you your bowel program or the time's all messed up and then they have to give more enemas and then that doesn't help you and it's more work for them, work together to reduce everybody's workload. It will reduce your anxiety and it will reduce their workload. Well, everybody likes to hear that. So, a lot depends on how you frame these things. So, anyway, I would like to thank you for coming today. It's been wonderful, and I'll see you next month on the webinar.